diagnosed, whether you're newly diagnosed to Turner syndrome or you're connected with Turner syndrome, or maybe it's been, maybe you're 30 or 40 years old living with Turner syndrome. And so we really want you to think about that, because that's the purpose of this webinar series. So again, we sincerely appreciate you taking the time. This is a new webinar series for us. This will be the first one, so I'm sure not everything will go perfect, but we hope you guys will give us our feedback. At the end of the webinar series, when you exit the meeting, you'll get a survey that'll pop up. It's 3 short questions, but we really want to make sure that you guys get the ability to say what's important to you, what's important to your loved ones, what's important to your knowledge when you think about Turner syndrome, the unanswered questions that we have, or wanting to know more about research as it relates to Turner syndrome. Again, our goal is to keep these meetings to 30 minutes. We know everybody has really busy schedules, but there'll be an optional time at the end for networking. So grab your coffee or glass of wine for those that you guys want to stay past the presentation. You'll first hear from our presenter. During this time, please put any questions into the chat. You guys should all be able to use the chat function so she can address them at that time, or she'll answer them at the conclusion of her presentation. If there's additional time, we will open up the discussion for additional questions at the end. If your questions don't get answered today, you'll have our contact information. Please reach out to us and we'll make sure we get you connected with our presenter today to answer any questions that don't get answered, or we'll send a summary of those additional questions as well. So we're going to go ahead and jump in here. As we get started, I want to first introduce you and thank a couple of my colleagues who are really partnered with us of putting this series together. So again, my name's Kelly Ranallo. I'm the co-founder. Mary Bell Good, who's in the background, but I told her she had to put her face up on screen here. She actually is a co-founder of TSGA as well. And then Liz Rowe is a parent advocate that recently joined our efforts and has been a big part of getting the series together. I want to tell you, before we get to our presenter today, I just want to tell you a little bit about TSGA. So TSGA, the Turner Syndrome Global Alliance, we were founded back in 2014. And really, we were just a bunch of moms that at the time were connected with TSSUS, our sister organization, and still are. But we were a bunch of moms that just said, we want better for our daughters. We had great resources. There were great conferences, but it was really hard to navigate. How do I find specialists that even understand Turner syndrome? How do I find all the doctors that I need to? Where do I get my information from? How do I make it easier to manage the healthcare aspect of my daughter's care? And so we formed an organization. We started out to really say, can we improve that access to care and that quality of care? And so we set out with a goal to set and create these comprehensive care centers. And so there's about 38 of them now across the country that are really founded on physicians that all understand Turner syndrome, all have a good understanding of the clinical guidelines, and in many cases, we'll be able to coordinate all of your care visits into one day. Once we kind of dealt with the model, we wanted to start now using that network of clinics to saying, we have a bunch of clinicians and researchers that are interested in Turner syndrome, but sometimes the biggest challenge with getting people to do research in any area or any disease state is either, one, you have to have a lot of money, because if you can fund researchers, they just generally will say yes, or you have to be able to show that a community is really committed. And that commitment can be participating with research, sharing research, or again, help funding. And we'll talk a little bit about that later. And so we wanted to create an opportunity for us to start gathering, whether those are insights from us as a community of what's most important to us, as well as being able to share some of our data that comes from our medical records. So we partnered with a couple of the centers. We started with 6 centers. I think we're up to 9 centers that are now participating. And we have the ability as a patient community to participate in what's called the InsighTS registry. So this is a patient registry that gathers data, both their surveys as well as our medical records, if you so choose to sign up to. And it's really sharing that data, all unidentified, but allowing to say, what my daughter's experience, was it the same as your daughter's experience? Or is my daughter's anxiety, when it presents, how many other girls' anxiety presents at that time, or things around growth, or things around cardiac MRIs. It allows us to gather all of that data. We hope that this is really going to be one of the largest research data sets that will actually lead to better outcomes and improving the health and well-being of individuals living with Turner syndrome, both from diagnosis through adulthood. So before I present my speaker too, I just want to give you guys this information because some of you guys may have to leave before the end of the presentation. One of the big questions people ask us all the time is, how can I help? How can I get involved? There's a lot of ways that you can get involved if research and improving the healthcare for either yourself or your loved one, your daughter, is important to you. You can make a monthly donation, and all of these are QR codes, so you can like use your phone and like look up them. They'll link them to all the sites, make it easy for you guys. All of the money that is raised from TSGA, 100% of it goes towards our programs for research. We're an all volunteer organization. We have been for 9 years now, because we want all of those funds directly related to research or to the care in the future. So there's an ability, if you can make a one-time donation, you know, many of us make monthly donations, and it doesn't matter if it's $2, $5, $10, $25, it doesn't matter. Every dollar counts when it comes to supporting our researchers to be able to have the staff to be able to put in all of the data that we give to them. You can enroll or learn more about the InsighTS registry. So if you're not familiar with the InsighTS registry and you want to learn more about it, you can click on that QR code. There's a good video that talks about it. There's information about it. And then if you want to participate, enroll, you can do that as well and share your own data or your child's data. Participate with research. You'll hear today there's a lot of research programs that happen outside that are being kind of pushed through the registry, that are individual, like the one today you're going to hear is about fertility. And so you'll have opportunities to do that as well. And then the next thing is just connect with us. You just being here today is a huge plus for our community, because really none of us can do it by ourselves. And so if you find this valuable, not only connecting, there'll be another series that comes up in March that'll be based on anxiety, and a research project that is being supported through us on anxiety. But also share this with your friends or other colleagues, family, other parents that maybe are connected, or other women that you're connected with that are impacted by Turner syndrome, because it's really about making people aware that these resources are available. So I'm going to transition my screen. I'm going to take this off for a second so that I can switch over. And so before the next step is, you guys, I just wanted to take an opportunity to introduce our presenter tonight. And, you know, as I asked her for her bio, she gave me her official bio, which I'll read that because I think it's really important that you understand the credentials that come behind this person. But I want to share a little bit about the personal story of how I got to meet we call her Dr. Tazim. That's what we call her. I think many of us call our doctors by their first name. But Dr. Tazim Dowlut-McElroy, my daughter and Allie's now 20, she'll be 26 next month, but we met Dr. Dowlut when she was 15 years old, because she was going through our clinic here in Kansas City. We're based in Kansas City, and she was having all these problems with bleeding, her menstrual cycle, those type of things. And our endocrinologist couldn't get it under control, so she referred us over to pediatric gynecology. That's where we first met Dr. Dowlut. I think it was truly, for me, the biggest gift in the world, because it was the first time somebody asked me, have you thought about her fertility? Have you thought about that aspect of her life? And of course, Allie at the time was a freshman in high school. I'm thinking about like homecoming. Does she have friends? Does she have a date? Does she have a dress? Those were my concerns at the time. But she made me really start thinking about that, because we know with Turner syndrome that fertility is something that's impacted by the condition. And so she really challenged both Allie and I, to think about it and to really do some testing to see if fertility preservation was even an option for her. It was at the time. And so Dr. Dowlut helped us not only find the specialists we needed to work through, but she helped Allie navigate that. She helped me as a parent navigate that. And we don't know what it's going to be. We don't know what the outcome is going to be. Allie hasn't made that choice yet to start a family, or even if the work that we did 10 years ago will result in her being able to carry a biological child. But what she did do is she empowered us as a family to start these discussions at a time that otherwise I might not have thought of. And by the time Allie got to the point when she was 28, 30, or wherever she was at in her life to think about family planning, the opportunity would have been missed for us. So I really appreciate that. She's been a good, not only I would honestly say not only amazing physician in support of it, but really a good friend to both me and Allie over the time. So I'll give you her formal thing. Dr. Tazim Dowlut-McElroy, she's a clinical scientist who specializes in pediatric and adolescent gynecology. She is board certified in obstetrics and gynecology and holds a focus practice designated in pediatric and adolescent gynecology. She is a fellow of the American College of Obstetrician and Gynecologists and holds various leadership positions in the North American Society for Pediatric and Adolescent Gynecology. She currently serves as a member of the International Turner Syndrome Consensus Group, which develops ongoing guidelines for the care of individuals with TS, and is a steering committee member of the InsighTS registry. Dr. Dowlut developed a transition clinic for adults with TS, as well as a research protocol studying differences in X chromosomes while working at the NIH, the National Institute of Health. She currently serves as the Division Director of Gynecology at Children's Mercy Hospital in Kansas City, Missouri, where her clinical practice and research focuses on TS ovarian insufficiency and hormone replacement therapy. So I'm going to quit talking and turn it over to Dr. Dowlut.
Thank you, Kelly. Thanks everyone for joining the TSGA and for spending a little bit of your Wednesday evening with us. Forgive my voice. I have laryngitis. Of all the times to have laryngitis, it was during my scheduled talk, but I will do my best. And if you have any questions, do put them in the chat. I'll try to answer as many as possible. Today's talk really is about fertility and fertility preservation in Turner syndrome. Before I start, I just have to make sure that you know that I am a member of the InsighTS steering committee, and also the TSGA has supported my research both at the NIH when I was there and here, Children's Mercy, Kansas City. Okay, so in order to understand options for fertility and fertility preservation in individuals with TS, we have to understand about the ovary. The ovary is where eggs are stored. And so one major function of the ovary is our ability to create biological children. But the second really important function, the second really important function of the ovary is that the cells around the eggs produce hormones. Typically, everybody knows that the ovary produces estrogen, but it also produces progesterone and also testosterone. Ovarian hormone function is important because we need functional ovaries that produce hormones in order to undergo natural reproductive maturation. So the ovaries produce estrogen that allow us to begin pubertal development, that allow breasts to begin to develop, that allows the uterus to develop and eventually have periods, and then that allows pregnancy to happen. But in individuals with TS, only about 45% will be able to have puberty on their own. Only about 15% will be able to have periods on their own. And on their own, I mean without medications and doctors helping. And only about 1 to 13% will be able to have children without help. And those rates are fairly low compared to people who have 2 typical X chromosomes and 2 functional ovaries. So the reason we're here today is that we know from both the recent research as well as older research that adults with TS continue to report that infertility is one of the major life issues that negatively affects their quality of life. And the question then to us clinical scientists from you, the TS community, is what can we do to help? And in order to explain that, I have to explain a little bit more about how ovaries work. So we, people who are born with ovaries, are born with a set number of eggs. So what we are born with is what we have. And the natural history of eggs or follicles in the ovary is that they die over time. That happens in people with typical ovaries and 2 X chromosomes that have no anomalies. But the rate at which those follicles or eggs die in the ovaries occurs in such a way that it still allows us to go through puberty on our own, typically about age 10 to 11, have periods on our own, typically 12 to 13, and then have peak fertility. We're most likely to get pregnant before our mid-30s. And then the eggs or follicles continue to die off. And by the time we're age 50 or 51 on average in the US, there are not enough follicles in the ovaries to allow us to have biological children or to produce hormones. And so menopause happens, our hormone levels decrease. But in kids with TS, we know that they're born with less eggs or follicles at birth, and that the rate at which those follicles or eggs die is much faster than in people who have 2 X chromosomes and typical ovarian function. And the problem is that although everyone with TS is at risk of having what we call ovarian insufficiency, which is when the ovaries run out of eggs, we really don't know at what point in life that's going to happen. Wouldn't it be nice if I could tell you that you or your child would have ovarian insufficiency at age 35, say, and then you could plan your reproductive life, hopefully based on that, and then have no surprises? Or wouldn't it be nice that I could tell you that your child will have functional ovarian follicles until age 10, and then you'd know, well, we should do something for fertility preservation before then? The problem is there's no way to predict even today. What we do know is that when you compare people with TS in whom a portion of their cells contain 2 normal X chromosomes, that their reproductive lifespan is a little bit longer than kids or adults who have just one X chromosome in all of their cells. So if I have TS and I have 45X karyotype, I know that I will likely go through ovarian insufficiency at a much earlier age than if I have TS and a portion of my cells have 2 normal X chromosomes. But even then, the exact time in life is completely unpredictable. We also know that the people with TS who are most likely to become pregnant have had periods on their own without any type of intervention, and that a portion of their karyotype, the proportion of their cells, have 2 normal X chromosomes. But the thing about TS and karyotyping and mosaicism is that when we as physicians give you a karyotype for you or your child, it's usually from a blood draw. So we look at chromosomes in white blood cells and we tell you this is what those show. But the level of penetrance of mosaicism is different in all the cells, meaning it's possible that the karyotype that you're given that's in white blood cells is different than, for instance, a heart or the ovaries. This is why we think some people with 45X can become pregnant. Some people with 45X, 46XY can become pregnant. It's because the karyotype in the white blood cells, what we usually report, may not be the same as the karyotype in the heart, the brain, or anywhere else in the body. When people with TS get pregnant, you need to know also that they're at higher risk of pregnancy complications. So the miscarriage rate is as high as 48%. In people without TS, it's usually about 15%. There's a higher chance of birth defects in the babies, 0 to 24%, compared to about 3% in people without TS. People with TS who get pregnant are much more likely to deliver by C-section. They're much more likely to develop hypertensive or blood pressure disorders during pregnancy, including preeclampsia. And they're at a much higher risk of having the aorta, which is a big blood vessel that takes blood from the heart to everywhere else in the body, tear, either during pregnancy or in the postpartum period. And that's very dangerous. And there have been reports of death when that's happened in people with TS. Which is why we have to acknowledge that building a family, whether you have TS or not, doesn't have to look like everybody else's method of building a family. We all have options. We can foster children, we can adopt, we can do donor egg, we can use a gestational carrier or a surrogate if it's too dangerous for us to carry our own baby, or we can choose not to have children. The picture on the top right of your screen, that couple in Paris obviously has no kids because there's never any time to do that when we have children. And it's important that we discuss that as families and as providers with the TS community, that the way that one person builds a family may not be a way that another person builds a family. Still, we're here to discuss fertility preservation. And so today there are two methods of freezing. And the theory behind freezing is, what I told you is that what we think happens is that the eggs in individuals with TS die faster. So the theory is that if you freeze those eggs or freeze an ovary containing those eggs, that it arrests the death of those follicles. So they stay alive until we want to use them later. Today, there are two options for freezing. One is to freeze eggs, and the other is to freeze an entire ovary. In order for a person to be able to freeze eggs, they have to have had periods on their own without medications. So for people with TS, that's less than 15%, because most people with TS will not have periods on their own. Ovarian freezing can be done at any age, but there are risks because it's a surgical procedure where we remove an ovary. And we also don't know what effect that will have on that person's ability to go through puberty on their own later. So I'll give you an example. Theoretically, we have two ovaries, and we think that half of the eggs are in one ovary and half are in the other, but no one's ever done a study looking at that. So if I take an ovary out in a child, say, who's 6 or 7, to preserve that ovary, does that mean that I decrease that child's chance of going through puberty on her own by 50%? And nobody knows that, which is why ovarian tissue freezing in the TS population is still considered experimental. This is a little bit of an overview of the ways that we can preserve. So this one depicts how we can preserve eggs. One cycle of egg preservation takes about 2 to 3 weeks. The first part, most kids with TS don't have trouble with because it's subcutaneous injections of medicines, and most people with TS will have given themselves growth hormone for years. And that, it's the same type of delivery system where you dial the amount that you need and then you inject it under the skin. But the difficulty arises because that 2 to 3 week period of time is extremely intense. So there are very frequent blood draws, sometimes every day, sometimes every other day. There are very frequent ultrasounds done to look and see if those ovaries have eggs that are responding to the treatment and that will be able to be frozen. Some centers now are able to do transabdominal ultrasounds because adolescents very frequently can't tolerate transvaginal ultrasounds. But the procedure to retrieve the eggs is still typically done vaginally. However, the person who's going to have that procedure is completely asleep, so they don't feel or remember anything about the retrieval. And this picture shows it's a transvaginal ultrasound probe, and then a little needle is inserted through the vagina, and basically they remove the eggs from the follicles that way. And then the second way to preserve fertility in general is to freeze an entire ovary. So again, That means removing an ovary, which is typically done laparoscopically. So if you have kids who've had an appendix removed, it's with a camera in the belly and a couple of other smaller incisions, and that's how we do it. Once we remove the ovary, then we send the ovary to a lab and they remove the cortex, the white part of the ovary. So if you imagine an orange, the eggs live in the orange peel, which we call the cortex. And the actual orange itself is all the other cells that have to do with blood supply, etc. So we peel the shell of the ovary. The ovary is then cut into strips that are frozen. And then the goal is when that person wants to have children, those strips are unfrozen, they're thawed, and then they're put back into the body, typically in the pelvis, so that people can get pregnant the typical way with intimacy. But during that whole freezing, thawing, and putting back into the body process, more than 60% of the eggs or follicles are lost. And so what we know that this works, but we know that it works in people who don't have TS, who have the typical number of eggs at birth and at the time that the ovary is removed. So imagine in a person with TS who has less at birth, less at the time that the ovary is removed. We really don't know if there are going to be enough eggs left after those pieces of ovary are put back in the body for that person to be able to get pregnant. So it's possible that you decide to do this for your child, and it has no benefit at all in the future. That's important, and that's why freezing an ovary in kids with TS is still considered experimental. We have clues, however, as to whether or not there will be follicles when we remove an ovary. So what we know from recent research is that if the karyotype of that person shows a percentage of cells with 2 normal X chromosomes, they're more likely to have eggs or follicles in the ovary than someone who has structural anomalies like an iso-X or ring X. And that person is more likely to have follicles in their ovaries than someone who has a 45X karyotype. We also know that in addition to karyotype, we can get clues about whether or not someone will have eggs in their ovaries if they choose to have an ovary removed. There are 2 hormones. One is called an AMH, anti-Mullerian hormone, and the other is FSH, follicular stimulating hormone, where if we put the 2 together and there's enough AMH and the FSH is low enough, that predicts that that person will likely have follicles or eggs in their ovaries. And we also know that people who can start puberty on their own, who have some breast development on their own, are more likely to have follicles when they have an ovary removed for freezing. I want to talk a little bit about AMH because it's increasingly used in clinical practice, and you might already have encountered this with your kids or not, or yourselves. So AMH was discovered really and was used, was used as a method of predicting whether an adult woman would respond to IVF. And I'm having technical issues. Okay, so when we're kids, we have all these eggs sitting in our ovaries, but they're not really doing anything. They're just kind of dormant. Once we go through puberty, then they start to develop and they become bigger and bigger until the egg is mature and we ovulate. AMH is only secreted by eggs that are developing. But I just told you that most of the eggs in children are dormant and not developing. So in kids who are prepubertal, that AMH level may not tell you or us about whether or not the child has follicles in their ovaries. So a low AMH in a prepubertal child does not necessarily mean that there aren't eggs or follicles in the ovaries. We do know from research, though, that AMH tends to reflect the amount of eggs in the ovaries. And this is a complicated chart, but basically the higher the AMH, the more likely that person is to have eggs in their ovaries. But again, if you look way over here on the left side, there are people who had really low AMH levels and still had a significant number of follicles in their ovaries. So decisions about fertility preservation should not be made based on AMH level alone in a child, in a prepubertal child. So we don't usually use AMH as a marker for whether or not fertility preservation will work or whether that child will have eggs in their ovaries when they're less than 11 or 12 years old. Okay, one additional thing is increasingly, and you may hear this at your doctor's visits, we are thinking about whether or not we should test more than one cell type to figure out if that person will have eggs or follicles in their ovaries as a way to counsel about ovarian freezing. So it is possible that if you get a blood draw and the karyotype is 45X in the blood draw, that if you get a buccal smear, which is from the mouth, that karyotype will be different. Then that one will say 45X, 46 double X. And again, that's because of mosaicism and penetrance. And so decisions about fertility preservation are increasingly going to be made based on not just one karyotype, but more than one karyotype. And you can do that with cells from the mouth. You can do that with cells from the urine. And I put this slide in here because, again, there are people who have 45X who are able to get pregnant. And the reason we think is that the karyotype in their ovaries are different than the karyotype in their white blood cells. Okay, however, I spent the last 20 minutes talking about follicles, and we don't want follicles. We want a baby. I put this in here to sort of give you a concrete view of the way, the chances of having a baby with freezing eggs or ovaries today. So when a person with cancer, a child with cancer, has chemotherapy, and if they freeze their eggs, their chance of having a live birth on average is 32%. So it's not high. And that's a person who has typical functioning ovaries with a higher amount of ovarian follicles or eggs in their ovaries. The chance of having a baby, if that type of person has an ovary removed and then thawed and put back into their body when they're older, ranges from 19 to 33%. There are centers that report about 50% success rate. But whether or not the chance of having a baby with either egg freezing or ovarian freezing for a person with Turner syndrome is absolutely unknown. There's only been one report of a person with TS who was able to freeze eggs and use those eggs to have a baby. She was in her early 20s. She was a mosaic. She had mosaic karyotype. She was in her early 20s when she had eggs frozen, and she was actually able to have one baby on her own. But when she tried again, she couldn't. And then she used her frozen eggs and was able to have a baby. But that's one, right? And then there have been 2 adults with Turner syndrome who have had their ovarian tissue put back into their bodies, and it didn't work. The reason I put this up there is because I don't want you to think that it will work if you choose that as an option for your child or yourself. Because the last thing we want to do is give anyone false hope. So fertility preservation remains completely experimental in individuals with TS. In making a decision to freeze or not to freeze, we also, as providers, think about the ethical considerations. So, for instance, if a child wants to freeze eggs or wants to freeze an ovary, sometimes we're talking about freezing an ovary in a child who's 2, 3, or 4 years old. And the ethical difficulty with that is that obviously they're not at an age where they can really understand what this means. And we continue to struggle with that. I'll just tell you that in research, we like to consider patient autonomy, which is their ability to make a decision about their own body and themselves. The difficulty with TS, though, is that if we wait till they're 15, 16, 17, or 18, it might be too late. And so we as providers and scientists keep in mind that there is still an ethical quandary about taking out an ovary or freezing eggs in a child when they're not adults. The other problem with fertility preservation is that in the United States, at least, there's not equal access. Most insurance companies do not cover fertility preservation in people with TS, or they'll cover some, but not all. And so these potential options for fertility preservation in this country really are available to wealthy people. And the last issue is false hope. I put that up there because there have been reports of children who have adolescents who have undergone ovarian tissue cryopreservation. And then when they were told after that tissue was looked at in a lab that there were no follicles, they became severely depressed and one became suicidal. Now, intervention prevented bad outcomes for those kids, but I put this slide up there to remind us that in weighing our decision for our children and for ourselves about whether or not to proceed with options for fertility preservations, we have to think not just about the physical ramifications, but also emotional ones. It's difficult to go through a 2 to 3 week period of injecting because the hormone levels shift so much during that time that people feel completely different. And imagine doing that when you're in junior high school or high school. And then it's difficult to have surgery when you're 2, 3, or 4, or even 7 or 8, when there's a little bit of understanding about what's going to happen, but not completely, I don't think, about why we're doing this for these children. Few points for your consideration. This is what we discussed at the International Turner Syndrome meeting that took place earlier this year. So we think that when the time is right, that families should discuss the potential for decreased fertility with children with TS and options for family building. But that means when the time is right for you and your children, because it's different for every family. For us as healthcare providers, what we recommend is that that everybody gets an opportunity to talk about fertility and fertility preservation as soon as possible. And that's going to be up to you as parents, families, and people with TS. But that referral, the person you're sent to discuss that, is someone who has knowledge about Turner syndrome, because fertility and fertility preservation for other kids and other groups of individuals with other conditions is different. The second really important point is that AMH level, that there's a recognition that even in a single individual, that level can change over time. So if I get an AMH today, it may not be the same as it will be in 6 months, 12 months, or a year. And that decisions for fertility preservation should not be made based on one level alone. And decision for fertility preservation should not be made based on just the AMH alone either. I'm going to take a look at the chat, but I wanted to put this up here. This is a study that I developed with help of people from the TS community. And if there are any people on the call that helped me with this, thank you very much. It's a survey study that I created because what we discovered, especially during our meeting in Denmark this year with the TS fertility work group, was that we as scientists and clinicians have a whole lot of ideas, but we really don't know what you in the TS community feel about fertility and fertility preservation. The survey is for people with TS age 12 to 25 and their parents. And it's just about attitudes about building a family in the future. It asks nothing about intimacy. It asks nothing about contraception. It's questions such as, do you think it's important for your children to know that TS may affect their ability to have children? Would you consider adopting? Would you consider a procedure like freezing eggs or ovaries if the doctor couldn't tell you whether or not that would help you have a baby in the future? So if you're interested, please take the survey, and I put my email and phone number on here in case you need to reach me about the survey or anything else. I'm going to quickly look at the chat. The first says, I have mosaic TS and conceived my daughter spontaneously with no intervention at 35 years. How common is this? What are the chances my daughter also has TS? We recently had a karyotype done, but are waiting on the results. So the fact that you have TS and were able to conceive at age 35 is an absolute blessing. It's not that common. There is a chance that your daughter might have TS, but there's also a chance that she doesn't, because TS is not usually passed down. There are rare chromosomal changes in which TS can be passed down to our daughters, but typically not. Good luck. And if you have any questions about the karyotype when you get it back, please contact me. I'm happy to help you. Okay, there's a question about the process for what is the process to determine the karyotype related to ovarian function, specifically for a child now 4 years old who's diagnosed with 45X TS in utero. Okay, so number one is that if you're considering fertility preservation, because it's still experimental, do it at a site that has an IRB approved protocol. Do it at a site where there are protections in place for the family and for the patient. Right now, the NIH has a study for fertility preservation in young kids, and they start at age 4. So the process in general is that we would take a complete medical history of your child, because TS affects different parts of your body. So we would know everything, including heart. Then we would do blood work. But again, we can't predict whether or not that person will have eggs in their ovaries just by blood work alone. And we certainly can't predict it with ultrasound. So the process is to just have a very transparent discussion with the investigators and the clinicians to talk about what to expect in the future, that it may work, but it may not, surgical risks, and then make a plan as a shared, it's called shared decision-making, where we really make a plan together with the person and the family as to whether or not they want to have a procedure. What is the percentage of success with women with TS using donor egg? I don't know those numbers because I'm not a reproductive endocrinologist. In general, it depends on the eggs. It depends on the quality of the eggs. Typically, donors are 32 years or young and younger because the quality of the eggs are better. But each individual center that does infertility and donor egg treatment has to report their success rates to the Society of Assisted Reproductive Technology. It's S as in Sarah, ART. So if you just Google SART, you'll be able to then, you'll be taken to a website where you can look at success rates for individual centers, whether it's using self eggs or donor egg. One thing I will say about pregnancy with donor egg is that because of the higher chance of complications of pregnancy in a woman with TS who chooses to become pregnant and carry a baby, we recommend that person, before they try, sees a group of physicians who have expertise in people with TS. So you need to see a high-risk OB doctor who knows about TS. You need to see a cardiologist who knows about TS, an obstetrician, and an endocrinologist, at least, because there has to be an assessment that takes place, including an MRI of the heart, to be able to tell you how risky is it for you to have to try to have a baby when you have TS. Are there ways to improve the follicles or eggs that you do have, even being in your early 30s with mosaic TS? No, not yet. Maybe that'll be a future thing, but what you were born with is what you have, and that's just how it is. Are there locations you would recommend for fertility preservation? Here's what I would say. It's not really about the location, more about the experience of that center with helping people with TS. So we don't really know everything. We know that there should be consideration for differences in approach when you're trying to freeze eggs in people with TS compared to people who don't have TS, because the follicles may be different. And so sometimes what happens is that if you give the same protocol, the same medications to a person with TS compared to a person without, the person without TS gets more eggs than the person with TS. So what I would suggest is, if you're interested in pursuing fertility preservation, if it's freezing eggs, then call around, meet the doctors, and figure out if you're comfortable with them. You can ask me if you want, and I can call for you. And if you're considering freezing an ovary, then go to a center where there is a research protocol in place for that. Can you say more about FSH and what ages FSH levels are indicative of fertility potential? Okay, so FSH is a hormone that's secreted by the brain. And what happens when the ovaries run out of eggs or follicles is that the FSH level goes up. So the FSH level in someone who's menopausal, who's 65, can be upwards of in the hundreds. But the FSH level in a prepubertal child should be much lower than that. The FSH level, once we go through puberty, it shifts and it goes up initially. And then if we don't get pregnant, it goes down. So that's different than AMH. AMH doesn't have that many fluctuations. So FSH is predictive of response to ovarian stimulation, so IVF, in post-pubertal people. If a person has gone through puberty, we check an FSH usually on day 2 or 3, so the second or third day of the menstrual period. And that can help predict the response of that person to IVF, but it doesn't predict whether or not that person will be able to have a baby. And it's the same with the AMH. AMH is just a way to look at, are there follicles in the ovaries? But a low AMH doesn't mean you won't have a baby, and a high AMH doesn't mean that you will. They're just clues. We now are beginning to check FSH levels on children way before the typical age of puberty, 11 or 12, because what we've seen is that sometimes the FSH level starts to rise in kids with TS even before puberty, 6, 7, or 8, and that gives us a clue as to the amount of eggs left in the ovaries. And I say a clue because we don't really know. I have no idea what an FSH level of 2 is in someone who's 6 compared to an FSH level is of 6 in someone who's 6 years old. It's just, there's a lot of stuff that we don't know. And that's the biggest thing I wanted to tell you today, is that there are too many things that we don't know. We need your help to figure out what to focus our research on. And we hope to be able to answer these questions in the future. Any other questions? You can email me at that email address, whether or not you participate in the study. I'm happy to help with any questions. That phone number is the phone number to the surgery, Department of Surgery here at Children's Mercy. I'm usually not at this spot at my desk. And so if I give you my office phone number, no one will ever answer it, but at least you can leave a message at that number and I'm happy to call you back.